Good afternoon, everyone, and happy Wednesday. Today's training is Psychiatric Injuries, Report Analysis and Rating with Tim Mussack of Bradford Barthel's AMA Analysis and Rating Department. And we are thrilled to have guest speaker, Dr. Ron Heredia, who is the Chief Operating Officer at Dr. Bruce Leckart and Associates. We're going to start with introductions. Tamina, would you like to start us off?
Sounds good, Tammy. Thank you so much. Good afternoon, ladies and gentlemen. My name is Tamina Ahmed. I am the Managing Partner for Client Relations at Bradford Barthel. And I was reminding Dawn this morning that I've been with the firm for 23 years. I am in the Woodland Hills office. We recently moved from Tarzana. We appreciate the opportunity to be here today and to present these fabulous speakers. So I'm going to let them go ahead and introduce the other speakers, introduce themselves, the other attendees, I mean. So I think, Kenny, it's your turn.
Great, thank you. Good afternoon, everyone. My name is Kenny Tolbert. I've been in the rating department for Bradford Barthel since January. I think you're in for a really good webinar today. Psych injuries are pretty interesting, and they're certainly different than physical injuries. So I hope it serves you well, and I'm glad to be here with you. Thank you.
Thank you, Kenny. Susan.
Hello, everyone. This is Susan Colias. I've been with Bradford Barthel for 10 years, 7 of which were as a hearing representative for the lien department. And I've been 3 years in the rating department.
Thank you, Susan. Dr. Heredia.
Hello, everybody. Welcome and thanks for attending. I'm Dr. Ron Heredia. I work with Dr. Bruce Leckart and Associates, and I'm happy to be here to provide information about psychiatric injuries and what you see and we all see in psychological and psychiatric reports over the years. So, I welcome any questions, just throw that out there as we go through this presentation. Thanks for having me.
Thank you. Dawn.
Yes, good afternoon, everybody. Thanks so much for joining us. I know you're very busy, but I guarantee you are in for a treat today. You've got 2 of the most respected expert presenters on the topic of today's topic, and it really, if there's nothing more fascinating in California workers' compensation than psych claims. Tim has been with the firm for a long time at this point, and we sure are glad he is. He has been in workers' compensation since 1988, so he's got me by just a couple of years. His background includes training and auditing of claims in over 30 jurisdictions, so he really knows the area with his primary experience, of course, being California. Does he know permanent disability? He's been instructing permanent disability since 1991, and he's taught the 1978 schedule. Anybody old enough to remember that? The 88 psych revision, the 97, the 2005, the 2013, et cetera, et cetera, et cetera. Tim, Susan, and Ken, their rating department, well, they don't rate, that's the wrong word, because anybody can adjust for FEC or the 0.4 adjuster, occupation and age. What they really, they'll do that as well, but what they really do is to make sure that the AMA guide's been properly applied. And they've reviewed over 25,000 such reports and found that about 80% of the time they actually overstate the amount of permanent disability, sometimes by tens of thousands of dollars. So as a result, their department has actually identified many, many millions of dollars worth of potential savings in permanent disability for defendants. Their work has been found to be so valuable that we even had other defense law firms come to them for doctor report analyses to help them prepare for negotiations, points and authorities, applicant and doctor depositions, and explaining to the judge and the DEU how settlement figures were derived. So very, very valuable. I want to make one other point about that fact. As a result, having examined over 25,000 reports, they've got a little black book, the good, the bad, and the ugly, on the physicians up and down the state of California, whether they be TPTs, PTPs, QMEs, or AMEs. So if you're facing a panel of 1, 2, or 3 doctors that you don't recognize, somebody's proposing an AME, or you just want to get some background on a doctor who, well, for whatever reason, we've got the information. So please feel free to email me or email one of them. We've got the little black book, and also since we're a statewide firm, we've got offices in every jurisdiction of the state, and so we can also inquire of the managing partner of that local office and their attorneys and get some insights for you. And that's all I have, with the exception of one joke. So you take one thing away from me, and here it is. So two elderly couples are visiting, and the two gentlemen are in one room and the ladies are in the other. And one gentleman says to the other, wife and I went to a great restaurant last week, brand new. Food's really good. Service excellent, and prices were not unreasonable. I was really recommended. Says this woman, we're always looking for a good new restaurant. What's the name of it? First guy says, well, what's the name of that flower? With the long stem with the thorns, it's red, and people give it away for Valentine's Day. Second guy says, that's a rose. That's right. Hey, Rose, what's the name of that restaurant we went to? Okay, I apologize. This presentation is going to get a lot better. Enjoy.
Oh, boy. Thank you, Don. I'm Tim Mussack, and here we go. We're going to talk about psychiatric injuries, report analysis, and ratings. We got two parts to it. My part, which is the basics, and then Dr. Heredi is going to give us some more detail. But first, Tammy's got some questions to ask, and I'm hoping you're going to try to answer.
Okay. Our first poll question, we have a few poll questions for you today. How many ratings have you completed since January? You should see that on your screen now, and clearly you do, because some of you are already entering the answers. But you have 4 options: 0, 1 to 2, 3 to 5, or more than 5. Again, how many ratings have you completed since January? Plug in your number there really fast, and I will share the results in about 3 seconds. I'm going to close it now. And Tim, here's those results.
Okay.
Can you see them on your screen?
I cannot see them on my screen.
You cannot?
I cannot.
Oh, okay. So 43% said more than 5.
Excellent. So we have some experienced raters here, and that's good. Thank you. Thank you.
We have a 29% who said 0, just so you know.
Okay.
And I'm going to go to the next question here. Okay. How many psych reports have you received since January? How many psych reports? Same options there: 0, 1 to 2, 3 to 5, or more than 5. And you guys are fast. I'm just going to give it a few more seconds here, and we're going to close this out. And I'm going to share these results now. So for the psych report, the highest percentage is 1 to 2, 38%. 24% said 0, and more than 5 was 16%.
Okay, good.
Okay.
Thank you for sharing that. I am seeing results now. Thank you. Okay.
And then the final question.
One more.
What does GAF mean specific to workers' compensation? You have 4 choices there again: global assessment of functioning, graduating attendant fractions, government approved fundamental, or none of the above. I'm going to give that just a couple of seconds here because you guys are so great. Thank you so much. And my light likes to go out while I'm on here, so I apologize. I'm in the dark now. Okay, here's the results. 90% said global assessment of functioning. Is that correct?
That's the correct answer. Thank you. Thanks for participating in that. We're going to talk a little bit about global assessment of functioning today. Maybe at the end of the session, 100% will get that right. That's good. So here we go. Part 1, review of a report for rating. Part 2 is going to be Dr. Heredia giving us some more details on how to identify and further address flaws in a psych report. So here we go. Review of a psych report for rating. When you get psych reports in workers' compensation, there's 2 labor code sections that you really got to know. Labor Code Section 3208.3 discusses compensability, and there are definitely some rules for what's compensable and what is not. Doesn't mean somebody might not have a psych injury, but whether or not it's compensable under workers' compensation. Labor Code Section 4660.1 is more specific to dates of injury 1/1/2013 and further limits what's compensable permanent disability for psych injury. You can still have temporary disability and treatment for a psych injury, but Labor Code 4660.1 limits permanent disability, compensable permanent disability for injuries 1/1/2013 and thereafter. I'm going to keep going. Psych injuries. Since 2005, we've been using the AMA guides for evaluation, finding the nature of the physical injury or disfigurement in our ratings. Chapter 14 of the AMA guides covers emotional behavioral disorders. Percentages are not provided in the AMA guides because there's no precise measures of impairment in mental disorders. That's from page 361 of the AMA guides. So what the administrative director did when they were creating the 2005 rating schedule to correspond to our use of the AMA guides, 5th edition, they needed something for us to be able to rate psychiatric injuries. Its compensability is established in California, and we're not going to do away with that. There's been limits, but we're not going to do away with it. That's a compensable injury in California. So what the administrative director did was they looked to the American Psychiatric Association and the Diagnostic and Statistical Manual of Mental Disorders, the DSM-4, published in July 2000, and the diagnostic criteria under Axis 1 through 5 included the global assessment of function. Was really intended as kind of a prognosis for evaluating physicians to kind of keep tabs of how a patient is doing. It wasn't intended to evaluate workers' comp, but we're using it for workers' comp. The doctors, when they're evaluating psych injuries, are to offer a global assessment of functioning, a scale of 0 to 100. And I've got something to show about that later. Back to the AMA guides, chapters 13 and 14 both cover emotional and behavioral disorders. Chapter 13 addresses that from a neurological or brain injury, and chapter 14 discusses it from a purely psychiatric perspective. So what we do when we're rating for workers' compensation, if it's a psych injury, we're using the GAF scale and evaluating that way. If it's a neurological or brain injury that's causing an emotional or behavioral disorder, we look at chapter 13, and there's a different rating methodology, similar but different. The way the AMA guides is designed and our rating schedule is designed, person's not going to get both. They're going to get whichever one applies to that injury. So Axis 1 through 5 from the DSM-4. I did want to mention that the DSM-5 was published in May of 2013, and that does not use the GAF anymore. We still use it in work comp. We did not do away with that. They have not come up with an alternative. We still use the GAF. So Axis 5 is the diagnosis piece that offers the GAF, the Global Assessment of Functioning. It's not in the AMA guides. Where do we get WPI? Well, the GAF is a score of 1 through 100, and 1 being the person is not functioning well. GAF 100 means that person is functioning about as well as anybody ever has. And the administrative director and their group put WPI values associated with it. So somewhat randomly, but they are in order. So for instance, a GAF of 60 corresponds to WPI of 15%. A GAF of 70 is 0% WPI, so it's not rateable. And so the doctors will give us a GAF. Most of the doctors are aware of the scale we use for rating in California, but if they're not, we go right to the rating schedule and on page 1-16 of the rating schedule, and we get the corresponding WPI for the GAF that the doctor gives us within Axis 5. So to give you an example, we have this data. A hotel porter with a psych injury, the doctor offers that MMI a GAF of 64. We go to the rating schedule and we find that a GAF of 64 corresponds to 9% WPI, and we rate it. There's one and only one impairment number for a true psych injury. It's 14.01 and so on. And so we rate it like that. 360 for hotel porter. I think that individual was, 65 years old on date of injury. So that would adjust to 16% PD. So from the doctor, we get the GAF of 64, adjust to 16% PD in this situation. The GAFs are in groups of 10, and what we see frequently is somebody in the GAF range of 61 to 70, which according to the American Psychiatric Association corresponds to some mild symptoms or some difficulty in social, occupational, or school function. And the doctor, with that slight narrative, puts the person in the GF range they think that person belongs, and then up or down within that range. So anything from 61 to 70 would correspond to this narrative. GF of 51 to 60, that range looks for moderate symptoms or moderate difficulties with function. And there's a pretty significant range of WPI there, 29% to 15%. So what do we do when we get a medical report, a psych report? We do what we do with every specialty. We review the WPI reporting. We look to see if the doctor explains the WPI. And do they give evidence and reasoning? Does that GAF assessment, does that correspond with the other data that's in the report? And that data that we look at in the report, we're just looking for consistencies. We're not doctors. Dr. Heredi's a doctor, but the rest of us are not. We're looking for data that supports the assessment and the opinions from the doctor. We're looking at almost all psych reports will offer some data in these categories. Current complaints and symptoms, current activities. Is the person doing more or less than might be suggested by the GAF assessment? Interpersonal relationships, typically doctors review that. Mental status exam, some discussion about the actual examination, the discussion with the injured worker and what the doctor might glean from that. And then there's quite often psychological testing. And I will let Dr. Heredi talk more about the psychological testing. But when we're reviewing medical reports, any medical report, we're looking for the data in the report that supports the opinions that the doctor gave. We're not going to argue from a medical perspective. We're just looking from a logical, reasonable person type perspective. That's what we do as raters. That's what our attorneys do. That's what claims people do. We're looking for, does it make a logical, reasonable conclusion from the data that's included in the report? So with that, I believe it's time for me to turn over to Dr. Heredi, who's going to go through part 2.
Thank you, Tim. I'm excited to share information now about how to identify and further address flaws in a psych report. My contact information is here, but it will be available at the end as well. And as I mentioned a bit earlier, I work with Dr. Bruce Leckhart and Associates, and I've been working with the forensic psychology practice there for 21 years. In addition to that, I teach psychology at the community college level here in Los Angeles, where I teach a variety of courses. So essentially, I'm looking at psych reports all day, every day, and or teaching about psychology to college students. And I absolutely love my work. When I am looking at psych reports, I'm definitely reviewing the GAF score, looking for information in the reports about that the doctor gives to support the GAF score that they gave, right? The GAF score is one piece of information in every psych report. Today, I'm going to go through these next slides, provide a wealth of information for you on what to look for in psych reports so that you can essentially save money on psych cases. The way that I've learned and that I teach and recommend to save the most amount of money in with the psych cases that you get, in particular the psych reports that the doctors send to you all, is to look and identify ways that that report does not constitute substantial medical evidence. Stated another way, the report doesn't have any support for the GAF score the doctor gave or for the diagnoses that the doctor gives. So I'll throw this question out there. What is one, I know that 76% of you said that you've had a psych report, at least one, within the past year. What are the psych diagnoses that you all most often see in psych reports? I know you probably do the same thing that I do. When we get a report, probably turn to the back portion of the report to find what did the doctor diagnose, right? And then maybe the next thing we look for is, what is the GAF score? What is the whole person impairment rating? Is there maximum medical improvement or permanent and stationary status? Did the doctor say it was caused by industrial events, and so on? But first and foremost, we probably look to see, what is that psychological diagnosis? So the question is, what are the psych diagnoses that you most often see in psych reports? And just maybe think about that. I almost, as a psych doctor, I can almost guess or come up with the answer that you are coming up with, and that is major depressive disorder. And if you didn't think that, you're probably thinking anxiety disorder, like a generalized anxiety disorder, or an anxiety disorder not otherwise specified, and then maybe a post-traumatic stress disorder. Those are about the top 4 or 5 psychological disorders diagnosed in all work comp psych reports. And I feel, and I start out this conversation because I feel like the psychological diagnosis is the most essential part of the report because it's the most vulnerable piece of the report. The psychological disorder is vulnerable because the doctor must provide data or evidence in their report that supports the diagnosis they gave. And guess what? In all the psych reports, well, I shouldn't say all, 99% of the psych reports I've read in 21 years, and that's all I do every day, read psych reports. Mostly from work comp. There are many from personal injury cases throughout the country that I read as well. It doesn't matter the jurisdiction. None of them have enough data or support for the diagnosis the doctor gives. That's important because for work comp in California, Labor Code Section 3208.3 states 2 important key factors. One is there must be a psychological disorder in order for the case to be compensable or for the injured worker to receive any money or benefits from the case, right? There has to be a psych disorder. And then the second statement in the Labor Code section is that the psych disorder must come from the Diagnostic and Statistical Manual. Anybody know which version of the DSM or Diagnostic and Statistical Manual we are on? If you said the DSM-5, you are correct. Now, the DSM-5 is the most recently published manual, but it is not the most widely accepted. And the Labor Code says the doctor must use a version of the manual that's widely accepted nationally by practitioners in the field of psychiatric medicine. So what is the manual that's widely accepted? It's the manual that precedes the DSM-5. It's called the DSM-4 TR. TR stands for text revision. With that information, now I'm going to shift to the report, right? Imagine yourself getting a psych report from a psych doctor. You flip to the back, you find the diagnosis is, let's say for the purpose of this discussion, major depressive disorder. Now what, right? Well, now what I recommend that you do exactly what I do, and that is go through the report and find, is there enough data or evidence to support major depressive disorder? You're going to find the answer is no. I almost can guarantee that. Now, this is how you go through the report. There are 5 sections. There can be 5 sections of every psych report. 5 sections are listed on the screen here. I call them sources of data because in these 5 sections, the doctors can possibly put in information to support their conclusions, but they never do. Nonetheless, we go down the list and we check the sections. Number 1, we look at where the doctor talked about the patient's life history or complaints, where the doctor discussed their data from mental status examination, the psychological testing, where the doctor reviewed the patient's medical records, and then any collateral sources of information. I'm going to tell you exactly now what to look for in each section. In the first section, life history and presenting complaints. In this section, you're going to find everything that the doctor wrote about the patient, from where they were born, where they went to school, where they've worked in their life, who their family members are, and so on and so forth. You'll also find a section, or you should find a brief discussion of the doctor's current symptoms or complaints that they attribute to the patient. And so those are symptoms, complaints, synonyms, right? Mean the same thing. What did the patient complain about on the day of the exam? I've read, again, thousands of psych reports written by AMEs, PQMEs, IMEs. They all sound the same to me now. I'll tell you what they sound like when I find that section. It sounds like this. Miss Garcia presented with a complaint of depression and sadness. She said that she had pain in multiple areas of her body. She also told me that she has sleep difficulty, often waking up in the middle of the night. Miss Garcia further complained that she cannot remember where she puts her keys when she goes and parks in the parking garage at work. Give or take a few symptoms or complaints, that's all I ever read, right? I recommend you do exactly what I do in with that section of the report. Take a yellow highlighter, it's very easy, right? And you highlight the 1 or 2 words that are actually truly a symptom or complaint. I take whatever I've highlighted and I type it into a separate Word document for myself. I call the Word document the list of the patient's complaints. Simple. All I ever end up with is depressed, sad, pain, sleep problems, forgetfulness. Give or take a few symptoms, right? There are big problems when the doctors write up their report in that fashion. And the big major problem is that the doctor's report lacks a complete history of the symptoms or complaints. What is a complete history? A complete history would be providing more information about each of the symptoms or complaints. But all the doctors do is they give us those 1 or 2 word phrases of the symptom or complaint. They lack the history behind those. Okay, I typed in the screen here with big capital boldface letters, FIDO-C. That is an acronym, and I'll tell you what each letter stands for. It applies to the symptoms or complaints. The F is for frequency. The doctors never provide the frequency of the patient's symptoms or complaints, and they need to provide that information in order to have a complete history. For example, all the doctor has to do in the face-to-face exam with the psych patient is say, Miss Garcia, you told me that you complained about being depressed. What's the frequency of your depression? Or how often do you feel depressed? Miss Garcia could tell the doctor, oh, doctor, I'm depressed every day. Miss Garcia could also say, doctor, I feel depressed about 5 days out of a month. Okay, whatever the information is, we need to see it in the report. And unfortunately, the doctors decline to include that information. So with that, their report is problematic. It's lacking. We go down the list, though. I is for intensity. Miss Garcia, you said you're depressed. How would you rate the intensity of your depression on a scale of 1 to 10? 10 is the absolute worst imaginable, where you think you might have to go to the emergency room. Miss Garcia could say, oh, intensity is an 11, doctor. Or Miss Garcia could say, it's about a 3. Okay, we need to know that information as well. The doctors just don't put it in their report. D is for duration. Miss Garcia, what's the duration of your depression? How long does it last when you feel that symptom? She could say 24 hours. Ms. Garcia could tell the doctor, about 10 minutes in the morning, usually when I wake up. I'm usually depressed for about 10 minutes when I wake up too, especially on a day I have to work, on a Monday, on a rainy day, whatever it might be, right? Does that mean that I have a major depressive disorder? Absolutely not. But even worse, the doctors just don't put that information in their report. So their report is lacking. The O is for onset. Ms. Garcia, you said you're depressed. When is the first time you remember feeling depressed? What's the onset of that symptom? She could say, now I've heard all of these answers in exams in our office. Doctor, the very first time I felt the real depression is about 2 weeks ago when my dog died. I had him for 18 years. Or Ms. Garcia could say, oh, about 4 days after the work injury. Ms. Garcia could also say, I've been depressed since I was a young child and my parents had a traumatic divorce. Whatever the response is, we need to see it in the report. And as you can imagine from those three examples, we have to think about the case as it applies to the onset of the symptoms, right? 2 weeks ago when the dog died, aha, now we know it's not work related. How would we ever know that if the doctors don't find that information out and or put that information in the report? Or depressed since childhood? Now we have to think about the case with respect to pre-existing symptoms and or diagnoses before the work injury. And the doctor needs to address whether the depression has been aggravated or exacerbated by the events at work. Now, C, the last letter, C, is for course over time. Ms. Garcia, you said you're depressed. You told me you got depressed 2 days after the work injury. That's been about 3 years now. In the 3 years that you've had depression, has your depression gotten worse over time? Has it gradually gotten better? Did it go away and then come back at a certain point? What is the course your depression has taken over time, Ms. Garcia? Now, we need that information in the report as well, because what if it's revealed that Ms. Garcia's depression went away completely and then was aggravated or came back because her dog died? We need to know that, right? Especially for the rating purposes of temporary disability or permanent disability, etc. So why is a complete history of the symptoms or complaints important? Well, you could probably imagine all of the information we just discussed would be missing from the report, right? And I'll give you another reason. When the doctor diagnoses a major depressive disorder, or any disorder for that matter, all of the disorders have criteria or requirements that must be met. Those can be found in the Diagnostic and Statistical Manual, in the DSM. If you're using and you want to look at the DSM-4TR, I recommend we all have a copy of the DSM-4TR, especially the 76% of you who said that you've received psych reports in the last year, or the 24% of you who will probably get some in the future. Have a copy of the DSM, because then you'll be able to simply flip to the page where the disorder appears. The disorder for a major depressive disorder appears on page 356 of the DSM-4TR. It appears on page 160 of the DSM-5 if the doctor used that manual. The criteria are the same in both of those manuals for a major depressive disorder. A lot of the other disorders, the criteria change, but for major depressive disorder, it's the same. I bring that up and I'm talking about the requirements of the criteria on page 356 because when you read it, you're going to find it says very clearly in black and white, bold-face print, the person, the patient must have depression, so a depressed mood, or loss of interest and pleasure. Now, in this hypothetical scenario I've been talking about, Ms. Garcia complained about being depressed, right? So that's depressed mood.
The DSM criteria on page 356 say, depressed mood must be present most of the day, nearly every day. So just like in my college classes, I'm going to repeat it because it's so important. Depressed mood must be present most of the day, nearly every day. You got it? Most of the day is the duration. How long, how often do you feel depressed when you get that feeling, Ms. Garcia? Now, if she says 5 minutes, 2 hours, is that most of the day? I don't think so. I'm no mathematician, but most of the day probably and should mean at least half of the day, if not more. And I think you would agree. Now, it also says in the DSM, the requirement is nearly every day. Did the doctor put that information in the report? No. Even if the doctor did, what would they say? If Ms. Garcia says, oh, about 5 days out of the month, does that meet the requirements for a major depressive disorder? I'm no mathematician, but nearly every day seems to mean at least half of the month, right? Probably more like 75%. So we need to know the information about FIDO-C. We must have a complete history. The doctors just don't put that in their report. So it's a major flaw. Now I'm going to go back here. Number one, check. There's no information in that section of the doctor's report that supports a major depressive disorder. What about area number 2? What about area number 3, 4, and 5? You're going to find no, 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 and no. But let's take a look and see, and I'll tell you how to look for the information. Mental status exam. This is a section that should be in every psych report. Every psych doctor knows how to do a mental status exam. They know why it is important. A mental status exam, so that you know, is a portion of the face-to-face interview with the patient. It's usually about 15 to 30 minutes or so, and it's reserved only for the doctor's observations of the patient, of their behaviors, right? So no more, Miss Jones, tell me this, what do you complain about, what bothers you, what do you deny? No more of that. It's only what the doctor observes of the patient. The doctor should be making observations in the areas of mood, memory, concentration, insight, and judgment. They all know that, right? And they all know how to do it. They're trained before they can get their degree. Now, what do you think? Can a doctor observe a person's memory? They can. I'm going to show you how. But before I show you how, let me tell you that when I read psych reports from other psych doctors, remember for 21 years now, they all sound the same. This is what they sound like when I read the mental status exam section. Ms. Garcia presented as depressed and dysphoric. Ms. Garcia's memory was poor. Ms. Garcia had adequate concentration. Her insight and judgment were restricted. That's all the doctors ever write, give or take a few more words or statements, right? Now, big problem when the doctors make statements like I just gave you, the big problem is those aren't observations. And remember, this section of the report is for the doctor's observations only. What the doctors give us, I call summary conclusion. The doctor has summarily concluded the patient looks depressed and dysphoric. That summarily concluded that their memory was poor and their concentration was adequate. They didn't give us what they observed that led them to make those summary conclusions, right? That's the big problem. Now, what can the doctor observe? Of a depressed person, okay, the doctor can make statements in their report like, Ms. Garcia presented with a disheveled appearance. Ms. Garcia had tears in her eyes as she spoke about the work injury. She had themes in her narrative of hopelessness and helplessness and worthlessness. Ms. Garcia expressed suicidal thoughts. Ms. Garcia sat down and stood up often. Her leg was shaking. Her hands were wriggling. Whatever the observation is, the doctors need to write it in the report. And there are so many observations that can be made to lead a doctor to say somebody's depressed, right? Dysphoric, that's an interesting word. I call it a psychobabble word used by psych doctors often. Do you know what dysphoric means? I'll tell you. If you look it up in the Webster's dictionary after this talk, you're going to find that it means uneasy. That's it, uneasy. I'm dysphoric when I drive the 405 freeway, right, in Los Angeles. Does that mean I have a major depressive disorder? Nope. Everybody's uneasy at some point in their day or their week, right? Now, memory. How can a doctor observe a person's memory? This is how they do it. Pretend you're the patient. I'll pretend I'm the doctor in the exam. Miss Garcia, or patient, I'm going to name 5 objects in your space, in your room. Can you please just recall those objects out loud when I ask for them? Ready? Screen, light, door, window, table. Got it? Tell me what they were. Now, Miss Garcia might say screen, light, door, table, window. Out of order, but completely okay. All the doctor has to do is write in their report, Miss Garcia was able to recall 5 objects in the examination room after an immediate recall. Now, maybe 5 minutes later, hey, Miss Garcia, can you remember those 5 objects again for me? At that point, she might say, oh, screen, light, door, can't remember the rest. Miss Garcia was able to remember 3 objects out of 5 in the examination room after a recall interval of 5 minutes. Simple. Put the data, put the observations in your report. I don't know why doctors don't do it, but what we do know is the what. The information is not there. Now, you might be picking up on this idea that I'm speaking about is where is the data? The doctors don't put in the information they're supposed to put in their report. That's key, because when defense attorneys can get this information, right, and draft questions or maybe get questions from the folks in my office about, or to go and cross-examine the doctor, they can ask questions designed to expose that the information's missing. Now, when we go down the line through the entire doctor's report and we find there's no information or data to support a major depressive disorder, then what, right? Well, remember I said there must be a psychological disorder in order for there to be a compensable psychiatric injury. That's key. I always imagine this as a house out of playing cards. When we were little, maybe we made those playing cards and built them up. Imagine the very bottom card being the diagnosis. And what happens when you swipe that very bottom card out from under everything else? Or you discredit the diagnosis, you nullify it, you wipe it away. Everything else crashes, right? It all tumbles down and you don't have to worry about it. I imagine the roof and the walls and the ceiling as the GAF score, the causation conclusions, apportionment, disability, and treatment recommendations. Those all crash, they go away if there's no supported or credible psychological disorder. And then what? There's no compensable case, right? Get the report dismissed, but even better, I think, a better option than getting the report dismissed is have the attorneys negotiate a more favorable settlement to your side. Save lots and lots of money, loads of money, tens of thousands of dollars potentially, right? Okay, that's my spiel on that. Let me move on to psych testing, make sure we get all this in. Every report, every psych report should have a section dedicated to psychological testing. I'll give you this one statement about psychiatrist versus psychologist. I recommend for IMEs, AMEs, or PQMEs, if you have the authority to select the discipline, select psychologist. Maybe treatment, go with psychiatrist, but psychologists for psych testing, because psych testing is so essential. Psych testing is the one area that can tell if the patient was faking or malingering. Psych testing is only, or psychologists are the ones trained in psych testing. Psychiatrists go to medical school for 4 years and then they do a residency in psychiatry for a couple of years. In all of that schooling, they are never required to go through courses of psychological testing, right? But psychologists are. So Psych testing is so important. It can assess a person's credibility. What you're looking for when you find that section of the doctor's report is, did the doctor give the MMPI? Minnesota Multiphasic Personality Inventory. It's absolutely essential because that's the #1 gold standard test of all psychological test batteries. And it is the #1 most researched test for being able to detect if a person is lying, faking, malingering, exaggerating, over-reporting, whatever you want to call it. Now, let's say you do find that section. You found the doctor gave some tests. You find the doctor did give the MMPI. Now you're looking for, did the doctor give the numbers, the scores of the MMPI? You need those scores. Every doctor should be putting those in the report. If they don't, call them up. Hey, I noticed you forgot to put the scores in your report. Can you send those out to all the parties in a fax? Don't let them write another report just to give you the scores that they already should have given you. Then you look at the scores, and what you're looking for, it's very complex, but I'm going to simple it down for you, right? Look for 3 scores first and foremost. F, L, K. F as in Frank, L as in Larry, K as in kite. Those are validity scales on the MMPI-2. When you look for those 3 scales, look at the score that's attached. If you find that the score is 65 or higher, then we need to discuss and look into it further. A score of 65 or higher in the according to the psychological literature says that those scores are interpretable. That means the doctor needs to say something about the scores. What should the doctor say? Well, for over 70 years in research, a score of 65 or higher on the F scale means that the person was attempting to simulate their symptoms or fake or malinger, right? Synonyms. A score of 65 or higher on the L scale means that they were not being honest and straightforward. A score of 65 or higher on the K scale means that the person was attempting to distort their true clinical presentation. Again, faking, malingering. I see those scores in a report. I expect to read further, and the doctor is going to say something to that effect. Guess what? Either I don't see anything, the doctor ignores the scores completely. They probably banking on the fact that you don't really know what the scores mean. Or if they do say anything about the scores, they say something like, well, Miss Garcia received these scores and they're elevated. That probably means she's crying out for help. That's the one doctor's answer to why Miss Garcia got those scores. If you send Miss Garcia's scores to another psych doctor down the street, or maybe the psych doctors in my office, they might say, oh, Miss Garcia received these really elevated scores on the #1 gold standard test because she was crying out for unwarranted work comp benefits. Which answer to why holds more weight? Neither. They're the same. But the what is important. And that's Miss Garcia received elevated scores on the MMPI-2. And the psychological research for over 70 years says that that means she was exaggerating or faking or malingering. And the doctor didn't say how they considered that when arriving at a major depressive disorder. So they should be questioned about it by the defense attorneys in a deposition is my recommendation. Let me go on to talk about the records. This is pretty quick and simple. All you're looking for in this section is, did the doctor review any other psych reports? Almost always you're going to find that answer is no. And in that case, we go back here, check. On number 4, no information there to support the major depressive disorder. What about number 5? Collateral sources of information. That is actually going to rarely be found by us in psych reports because it's only when the doctor needs to interview the patient's family, friends, or coworkers. And that usually only happens if the injured worker cannot speak or think for themselves. Perhaps they're deceased, perhaps they had a traumatic brain injury or a stroke victim, and they can't speak or think for themselves. But it's very, very rare, so you'll almost never find this information. Now, when the doctor's report lacks any data, to support a major depressive disorder, just like the house of cards, attorneys can expose that in a cross-examination or a deposition. The doctors are going to be forced to say, if the attorney uses the right questions, get the doctor to say, oh, that information is not in my report. I didn't put that information in my report. I didn't put any information about frequency in my report, about duration. I didn't put the observations in my mental status exam report. I didn't put the scores of the MMPI in my report. I didn't talk about why how I considered the elevated validity scale scores of the MMPI when I arrived at a major depressive disorder diagnosis. All of those types of responses from a doctor should be desirable, because at the end of an hour or a 2-hour long deposition by the defense attorney, I imagine they'd be in a better place, right? Yeah, with the doctor just saying, oh, the information's not in my report for a whole hour. I have on the screen here Apricot. I know that I love our working relationship with Bradford and Barthel and have loved that for many years. We've provided many Apricot reports for some of the attorneys with the firm where they were deposing psych doctors and asked us to give them a write-up of all of the major flaws in the psych report, as well as a script of simple questions to use in deposing the psych doctor. And from attorneys throughout the country, we find that we get feedback saying that saved, we negotiated, or the report was dismissed and it saved loads of money on the psych case. So if you find yourself in need of an apricot, I encourage you to reach out. Also, I imagine you'll get a copy of this PowerPoint where I provide some rules and tips for the attorneys that you can pass on to them when they are going to depose the psych doctor. These rules and tips are essential. I welcome any questions. I know Tim does as well, and thank you for listening.
Doctor, we do have some questions for you. You want to take a couple of questions?
Perfect.
Okay. One question that came in was if the examiner quotes the DSM-4 and not the DSM-4 TR, does that make a difference?
Oh, certainly does. The DSM-4 is outdated and obsolete. DSM-4 was published in 1994, and when the DSM-4 TR was published in 2000, they made many, many changes that are discussed in the back pages of the DSM-4 TR. The DSM-4 at that point became outdated and obsolete.
Next question came in. I think you went through some of it, but keywords to be able to indicate that maybe the doctor's not writing a fully objective report. And I think you kind of went through some of those things, but my assessment is many doctors in every specialty have some sort of a template, and just sometimes they don't clear the prior template. Go ahead, I'm sorry.
So is the question asking for keywords on what to look for in a report?
Correct.
Okay, so definitely the psych testing, the MMPI, mental status exam, and descriptions of what the doctor observed, right? In the psych and the symptoms or complaints, you got to find that section of a report and go through and use FIDO-C, the acronym, right? To see if the doctor put that information in there. When you find that all of that data is missing, that's when you know and you can be confident that the doctor's report doesn't have any information supporting their conclusions.
Next question, mental status exam. Person's looking at a specific report and looks like the doctor's adding complaints that might not fall within the mental status exam. Is that any kind of an issue? Is there a way to handle that sort of thing?
Yeah, that's where you find inconsistencies with the doctor's reporting, right? Typically, well, first and foremost, the mental status exam section, there is no place for reporting the patient's symptoms or complaints in that section. The doctor should be asked that. Doctor, will you confirm that you stated in your mental status exam report that Miss Garcia complained about being depressed and not sleeping well. Doctor, do you agree that a mental status exam is reserved for the doctor's observations only? Will you please tell me where in your report you discussed your reasons for stating her symptoms or complaints in the mental status exam section? Something like that. I mean, those are questions I would recommend an attorney ask in deposition to expose those errors on the record.
Another question is, what if the injured worker doesn't complete the MMPI testing? What does that do?
Okay, two scenarios. One is they started it and the doctor stated that, but then they don't finish. Big problem. The doctors are trained to know that they need to provide adequate lighting and ventilation and time to complete the MMPI. If they said, oh, time ran out in the day, okay, you got to schedule another day. The MMPI needs to be complete, not just started, right? That would be a problem created by the doctor. Now, if the doctor didn't give the MMPI, that's also a major problem with the doctor's methodology. Then we'd need to look, did they give any tests at all that is capable of assessing the patient's credibility? And there are only a few tests out there that can do that. Other tests are the MCMI, the Milan Multi-Axial Clinical Inventory, or Clinical Multi-Axial Inventory, I should say. The WAIS, the TOM, the Patel, those are the tests that come to mind that can be used to assess a person's credibility. If the doctors don't use any of these tests with validity scales, then that means they didn't take any action or methods to determine if the person was being honest and truthful with them. And that's a major problem in a psych report, especially.
And another question is, can you distinguish between stress at work and a psychiatric injury? What is the difference, or could be the difference?
Stress can be reported as a symptom, right? But stress is not found anywhere in the DSM except for one place, and that's post-traumatic stress disorder. So if you're, and I'm sorry, an acute stress disorder as well. So two places that you can find the word stress. Stress is relative, right? Meaning, Tim, your stress and what you might say is your stress can be very different from when I say, oh, I'm stressed out. What does that mean, right? The doctors need to go in and describe what the person means, what the characteristics of their complaint of stress are for anybody to know. Otherwise, it's just one of those psychobabble words thrown out there to make it seem maybe that the person's having mental health problems.
Thank you. Dr. Heredi, your information, email address is here on your screen right now. I would ask anybody else has any further follow-up questions, feel free to contact Dr. Heredi directly. And thank you, Doctor. And Tammy?
Yes, thank you both so very much. Thank you for joining us, Dr. Heredia. We appreciate it. Enjoy the rest of your week. Take care, everyone.
Thanks for your time. Have a great afternoon. Bye-bye.